Hello everyone, in this video, we will discuss on atrophic pap smear, differential diagnosis and pitfall. Atrophy or atrophic vaginitis is associated with hormonal deprivation, where there are thinning, drying, and inflammation of vaginal walls that may occur when the body has less estrogen hormone. Vaginal atrophy often occur after menopause, or we call it postmenopausal. The researcher attributed this to the strong correlation between estrogen deficiency and atypical squamous. And the researcher also concluded that estrogen therapy can revert the atypical squamous back to normal. Since atrophic cervicovaginal smear can exhibit various atypical patterns, they can easily mislead to overinterpretation and overdiagnosis of squamous atypical or even carcinoma. Atrophic pattern also can be seen in premenopausal women's pap smear. It is usually associated with estrogen deficiency, which may be results from chemotherapy or radiation therapy, prolonged use of certain medication, surgical procedure, genetic conditions or predispositions, postpartum period, prolonged or chronic stress, and also excessive exercise. The usual pattern of atrophic smear is characterized by the predominance of parabasal cells that can be grouped together in small clusters or as single cells, exhibiting scanty cytoplasm and a high nuclear cytoplasmic ratio. The smear typically lacks polymorphonuclear PMN debris and has a clean background. There is an absence of nuclear atypia, but nuclear hyperchromasia is present. Additionally, no chromatin clumping or nucleoli are seen. These characteristics help to distinguish atrophic smears from those indicating infection, inflammation, dysplasia, or malignancy. In the first picture, parabasal cells are seen arranged as single cells. The second picture provides a more varied arrangement, with parabasal cells appearing both as single cells and grouped together in a small cluster. Lastly, the third picture illustrates parabasal cells arranged exclusively in clusters, highlighting the different patterns these cells can exhibit in an atrophic pap smear. Differential diagnosis and pitfall. In atrophic smear, differential diagnosis can be divided into 5, such as reactive changes induced by radiation therapy, ASC-US, LSIL, HSIL, and SCC. Firstly is reactive changes induced by radiation therapy RT. Mostly, patients with radiation changes in pap smear can have atrophic smear. It is because by first is postmenopausal status. Second is previous oophorectomy. Oophorectomy is surgical removal of one or both ovaries. Third is radiation-induced atrophic changes of ovaries. Radiation changes that can show atrophic smear are usually associated with chronic radiation changes rather than acute radiation changes. Chronic radiation changes are cellular changes due to radiation seen after 6 months to 1 year. These are the features that show an atrophic pattern in reactive changes by radiation therapy smear. It can be observed by a lot of parabasal cells in smears. The characteristics are similar to the usual pattern of atrophic smear, except the cells can have binucleation and multinucleation. These 3 pictures are post-irradiation smears that show an atrophic pattern. In this picture, it has a variable number of squamous cells, and parabasal cells are seen scattered in an inflammatory background. Binucleation can be seen in the picture in the middle. Atrophy can be misinterpreted as atypical squamous cells of undetermined significance ASC-US in pap smear. The causes of mimicking are perimenopausal changes, inexperienced hands, and poor preservation techniques. In this case, the squamous cells will undergo nucleus enlargement that mimicking nuclear changes in ASC-US. Slightly high N or C ratio, binucleation or multinucleation, hyperchromasia, and also have inflammatory background. These are some examples of ASC-US in atrophic smear. The first and second pictures show binucleation cells, and the third picture shows a few hyperchromic cells due to delay in alcohol fixation. Low-grade squamous intraepithelial lesion LSIL and atrophic changes in pap smears are 2 different conditions, but they can share some similarities that might cause confusion in their diagnosis. There are some features that atrophic can mimic LSIL, such as 1. Background inflammation. LSIL often shows an inflammatory background due to the presence of HPV infection, while atrophic vaginitis can cause inflammation due to the thinning of the vaginal and cervical epithelium. 2. Nuclear enlargement. 3. High nuclear cytoplasmic ratio. 4. Hyperchromatic nucleus. Both atrophic changes in LSIL can show hyperchromatic dark staining nuclei. 5. Cell clumping and overlap. Both atrophic cells and LSIL can present with cell clumping and overlapping, where atrophy due to loss of estrogen and LSIL due to dysplasia. The major difference between atrophic and LSIL is that LSIL shows the presence of coilocyte, and atrophic will shows the presence of vacuolated cytoplasm. From both pictures, if we look roughly, there is not much difference right between them, but the treatment is different. So, we have to look carefully at each detail of the cells that can help us to avoid misinterpretation. The age and menopausal status of the patient can provide clues. HSIL is more common in younger and sexually active women, while atrophic changes are typical in postmenopausal women. Features that can mimic HSIL are nuclear enlargement. Both has scanty cytoplasm and cell clustering. We can differentiate between atrophic and HSIL based on nuclear chromatin pattern and the presence of red atrophy. The cell population and the presence of grooves also give a hint to differentiate between atrophic and HSIL. Blue blobs are only present in atrophic smear but not HSIL. This is because the epithelial cells lining the vagina and cervix can become thin and fragile due to decreased estrogen levels. This can lead to an increase in degenerative changes where cell break down and clump together, forming blue blobs. Atrophic smear can also be mistaken with invasive SCC. These are the key features of atrophic smear that mimics SCC. 1. Nuclear enlargement. Atrophic cells can have larger than normal nuclei, sometimes mimicking the nuclear changes seen in dysplasia or carcinoma. If it is uniform, we can say that it is atrophy. 2. Background of smear. Sometimes atrophic smear can have a granular background, basically from degenerating parabasal cells. 3. Due to inflammation, the background can also have inflammatory debris. Marked necrotic bodies as well as pseudoporakeratosis can also appear in the background, making it similar to tumor diathesis. These are the pictures that show features that can mimic SCC. There is a presence of necrotic bodies, pseudokeratosis shown in arrow, and basophilic granular background. In order to prevent this misdiagnosis, we have to differentiate closely enough between these atrophic cells and malignant cells. As we can see here, the nucleus of atrophic cells enlarged uniformly while malignant cells may have nuclear pleomorphism. In atrophic cells, there is no mitotic figure when compared to SCC cases. The obvious way to differentiate between these two cases is the shape of the cell. In atrophic cases, it is often predominated by parabasal cells, while in SCC, the cell shape is bizarre. To conclude all of the points, there are a few characteristics of atrophic smear which are predominant parabasal cells, scanty cytoplasm, and hyperchromatic nucleus. Whereas for differential diagnosis and pitfall includes atrophy pattern seen in post-radiation therapy, atypical squamous cells in atrophic smear mimicking abnormal cells in ASC-US, atrophic smear cells mimicking atypical cells in LSIL, cells arrangement in atrophic smear mimicking cell arrangement in HSIL, nucleus and background in atrophy mimicking nuclear changes and background of SCC. There are also a few suggestive strategies for correct decision-making. As cytoscreener, we need to improve our skills in screening Pap smear and be more competent in our work to avoid misinterpretation. Next, the cytoscreener or the pathologist also needs to consider patients' information before reporting and diagnosing. For example, patients' past medical history, age, menopausal status, along with the colposcopic appearance in colposcopic findings. These are the references that we referred to for this video. Thank you for your time, and have a nice day!